Thank you for the introduction. Let's see. If at any point you can't hear me or my connection is poor, please interrupt me and I will address it. So good morning, everyone. My name is Loredana Calci. I am a first-year perio resident at Stony Brook University School of Dental Medicine in Stony Brook, New York. And this morning, I will be discussing the thermal effects of ceramic implants after using a 940 nanometer and 980 nanometer diode laser. A brief introduction: the management of peri-implantitis with diode lasers is widely used in dentistry. However, there is no evidence on the thermal effects that occur on the ceramic implants during laser radiation. For this study, our goal was to evaluate the thermal effects of a ceramic implant after irradiation with a 940 nanometer and 980 nanometer diode laser at room temperature and in a 37 degrees Celsius water bath. Our experiment began with placing a ceramic dental implant inside of an organic bovine bone analog. An intrabony defect was created right beside the implant using a high-speed round burr, and this was to mimic the appearance of peri-implantitis. The intrabony defect was irradiated for 30 seconds using a 940 nanometer and 980 nanometer diode laser in 2 watts continuous wave and also in pulse mode. A non-initiated fiber tip was placed inside of the intrabony defect, and it was parallel to the implant surface, as shown in our study design here, figure 1. And this was done at room temperature as well as in a 37 degrees Celsius water bath. 2 thermocouple probes were attached to the coronal portion and the apical portion of the implants, as shown here. And real-time temperature changes were recorded in degrees Celsius throughout irradiation. A data acquisition tool was used for data collection and a descriptive analysis was conducted. I'm going to zoom into the results here. So table 1 and 2 are the average temperature changes that occurred on the ceramic implant in 2 different power settings, as well as the 2 different in vitro conditions. Figures 2 and 3 are the graphical representation of these temperature values. So in figure 2, we are looking at the delta T values after using 2 watts continuous wave, and the highest temperature change occurred at the coronal level of the ceramic implant when using the 980 nanometer diode laser. And as you can see, this temperature increase at room temperature went above that critical threshold of 10 degrees Celsius. As highlighted by this red line here. So any temperature value above this value has been shown to result in necrosis of the surrounding tissue. So a high temperature reading was also recorded for the 980 nanometer diode laser in the water bath. Although it did not reach the 10 degrees Celsius mark, it is very close to it. However, when using the 940 nanometer diode laser under the same power settings, the ceramic implant did not reach that 10 degrees Celsius critical threshold value. The ceramic implant was able to maintain temperatures below 10 degrees Celsius throughout the 30 seconds of irradiation, and this was in both in vitro conditions. And when this experiment was repeated using pulsed mode settings, in figure 3, we can see that for the 940 nanometer diode laser, these temperature values dropped to about 3 degrees Celsius change in temperature. So it was even lower. But however, the 980 nanometer diode laser did remain high. Again, although it did not touch the 10 degree critical threshold value, it was very close to it. So within the limitations of this study, our conclusion is that the 980 nanometer diode laser must be used with caution in the management of peri-implant defects of ceramic implants. However, the 940 nanometer diode laser in continuous wave and pulse mode seems to be appropriate for the use on peri-implantitis of ceramic implants. Thank you, everyone. Does anyone have any questions? If not, We are a little early. Thank you. Okay,
Excellent work,
so
Dr. Calte. And I want to emphasize, if anyone has questions, they can also write them in the chat box. In case we run behind in time, we will be able to communicate and keep the discussion going there as well.
that's right. I'll keep an eye on the chat box throughout our session here. Okay, so I will introduce our next presenter. Just give me 1 second to pull up our. Okay, so our next presenter is Kimberly Law, and she will be presenting a retrospective study, the association between marijuana use and dental implants. So if you can share your screen.
Give me one moment. And can you see my screen?
Yes, we can see your screen. How is your audio?
Can you hear me now?
It's a little low for my computer.
Okay, I can try speaking closer to the computer then.
Okay, yes, much better. Thank you, Kimberly.
Oops. Sorry, just a little bit difficult. Is it on presenting mode?
That's okay. Take your time. We have 11:08 until 11:16.
Okay, is it on presenting mode now?
I don't think it's presenting mode. I see your slides.
Okay. Let's see. I'm just gonna try. If not, I'm gonna just let you. Is it all right if I present it from kind of on this mode instead?
I'm okay with that.
Okay, I'm sorry about that.
Don't worry.
Hi everyone, my name is Kimberly Law. I'm a second year pre-doctoral student from Tufts University, and I'm going to be presenting the research I worked on, a retrospective study association between marijuana use and dental implants. And so just to give a little bit of background, one of the most commonly used drugs is marijuana. And with the recent legalization of marijuana, it has become an accessible drug and it could have impacts on the oral cavity. And marijuana has some types of anti-inflammatory components that help with pain, but it can also block the oral cavity from being able to defend itself against bacteria that could cause periodontitis or peri-implantitis. And so one study I found in my research was that marijuana affected the osseointegration process in mice, but had detrimental effects on healing processes on implants. But there's very limited literature on how marijuana affects dental implants on humans, and thus I want to explore what the association is between marijuana and dental implant survivability. And then, so the purpose of the study was to assess the association between dental implant survivability and marijuana smoking. And to do so, I reviewed patient charts who received dental implants and also who reported marijuana usage from June of 2004 to December of 2020. And the implants were then sorted into marijuana usage groups and non-marijuana usage groups, with a total of 473 implants in each group. And dental implant was considered to have survived if it was present in the oral cavity at the time of collection, and it was considered a failure if it was absent at the time. And we also took into account potential confounding variables. So we extracted other variables like patient-related data, like age and gender, dental-related variables like probing depth, and also implant variables like the length and diameter of the implant that was placed. And then here is just the general demographics. This is also the variables that we extracted. And we have here the marijuana smoking group variables and then the non-marijuana smoking. And then also there was some variables that were found to be significantly confounding to the studies. So it was important that we did a statistical analysis to eliminate the confounding variables. And so Dr. Tran worked on the statistical analysis, and we used 3 different types. We used the Kaplan-Meier analysis, which created the survival curves stratified by marijuana smoking versus non-marijuana smoking, the log rank test, and univariable Cox regression, which helped to assess the association between implant survival and marijuana smoking and covariates, and then the multivariable analysis, which determined the impacts of implant smoking on implant survival and correcting for those confounding variables that we found. And so here are the results. So we have the Kaplan-Meier survival curve on the left, and this, so the blue line represented the implants that were associated with marijuana smoking, and the red line up here represented the implants associated with non-marijuana smoking over a period of time on the x-axis and proportionality of survival. And then you can see that over time that the marijuana related implants had a significant drop, and thus we concluded that it was statistically higher survival rates in dental implants in non-marijuana smokers than marijuana smokers. And then on the right, we have the multi-Cox regression, the adjustments of the results to the confounding variable of age. And so once we adjusted that, the hazard ratio was 2.4, which can be interpreted that implants and marijuana smokers have a 2.4 times increased risk of implant failure than implants in non-marijuana smokers. Okay. And in table 3, we were showing the survival rates of dental implants between marijuana users and non-marijuana users. And so the marijuana users overall showed a lower survival rate compared to non-marijuana users. And you can see in the first 6 months between marijuana and non-marijuana smoking, the survival rates for the marijuana smoking is about 0.5% lower. But you see that there's a drastic difference over a period of time of 10 years where the marijuana smoking survival is 12.6 times lower than non-marijuana smoking. So as time progressed, survival rates between 2 groups have widened, and the marijuana smoking smokers, implants related to marijuana smoking had a larger drop in survival rate. And then, so to conclude, marijuana smoking was statistically associated with increased risk of dental implant failure in implants placed at Tufts from June 2004 to December 2020. And the risk of implant failure was 2.4 times higher in marijuana smoking patients than non-marijuana smoking patients. And that's it. Any questions?
There is one question in the chat. Did you measure the quantity of marijuana usage per subject?
So this was one of the limitations of this study. Because it was retrospective, we based it off of their medical history that they filled out. So it could go back to like 2004, where a patient would just fill out yes or no to marijuana usage. But I think that going forward, I think doing a prospective study would be useful, because we couldn't measure how much marijuana, how frequently, what types of marijuana usage. So I think after the study, it'd be good to kind of expand on that point so we can get better data out of this.
Thank you. Great answer. Any other questions? Okay, if not, we can move on. We can start setting up the next presentation, which is by Dr. Wu in Columbia, from Columbia. And his abstract is Engineering Periodontal Tissues on Titanium Surface for Treatment of Periimplantitis. Perfect. Okay, we'll wait until 11:16.
Hi, can you see the screen?
Yes, screen is visible and your audio is great.
Voice is okay. Okay, I'll just speak.
Okay, and you can begin whenever you're ready.
All right. Hi, my name is Hyun Woo, a third-year periodontic resident from Columbia University College of Dental Medicine. Today, I would like to present my research, Engineering Periodontal Tissues on Titanium Surface for Treatment of Periimplantitis. There's no conflict of interest to disclose. Okay. So periimplantitis is a chronic inflammatory condition with progressive and destructive bone loss. surrounding dental implants, which can lead to implant loss. Prevalence ranges from 10 to 40% per implant. Aim of this research is to explore a new regenerative approach of engineering cementum and functional PDL that can presumably serve as biological barriers to prevent or decelerate periimplantitis using PDL stem progenitor cells via bioactive hydrogel. Following RRB, healthy PDL cells were isolated and cultured from a single patient to target cementum and PDL. PDL-SC plus fibringenapine with BMP7 and CTGF was loaded on the titanium plate. The first layer of BMP7 loaded, and 1 week after CTGF layer was loaded. And to target cementum, PDL-SC plus fibringenapine with BMP7 was loaded. And the PDL-SC alone and the PDL-SC plus fibringenapine were prepared for control groups. After 4 to 6 weeks of culture, samples were harvested for histomorphometric and gene expression analysis. H&E stain showed most tissue formation in the presence of CDGF compared to other groups. And also PDL-SC alone showed that 2 to 3 layers of PDL cells well attached to titanium surface. Steven S. Blue and Van Geysen stain also showed that a tissue formation in 3 groups and PDL cells in blue in the PDL-SC alone group. So both H&E and SV stain show the mineralization in presence of fibringenapine hydrogel compared to PDL-SC alone. In the presence of CDGF, PDL cell became more spindle shaped and that looks like PDL fibroblast, while PDL cells look rounder in absence of CDGF, as you can see in these 2 images. And a relative aspect ratio of cells showed that in presence of the CDGF, PDL cells become more elongated and spindle-looking shape. Alizarin red showed the calcium mineralized tissue formation in 3 groups, where you can see in red, where BMP7 and CDGF showed more mineralization, but not in PDL-SC alone. And Picker series red showed the dense collagen formation with CDGF and immature collagen formation in other 2 groups, but no collagen formation detected in PDL-SC alone. And the PDL-SC plus fibringenapine hydrogel with BMP7 and CDGF group resulted in both mineralization and dense collagen formation. Further, BSC and SCEM images shows confirmed these mineralizations in 3 groups. And EDS and element analysis showed that these mineralized tissues are composed of calcium phosphate, where calcium is green, phosphate is red. Combining together, it becomes yellow. And BMP7, in the presence of BMP7, the mineralization is most densest mineralization confirmed. In gene expression analysis, collagen 1 and periostin relatively high in the presence of CDGF. And there was also a bone sialoprotein expression detected with in the presence of CDGF. And the mineralization relative area was highest in BMP7 group. Interestingly, there was a high CEMP1 expression detected in the PDL-SC alone groups. And also when the PDLs are in contact with the titanium surface, they express more CEMP1 compared to cultured plate. This indicates that a titanium may promote CEMP1 expression when PDLCs are in direct contact with titanium. To summarize, PDLC delivery via bioactive fibringenapine may promote formation of integrated periodontal tissues on titanium surface. Our approach with the fibringenapine, which provides a controlled release of growth factors and prolonged in vivo degradation for our previous studies, may have a significant translational potential as an injectable hydrogel that facilitates the reconstruction of periodontal tissues surrounding dental implants. This finding has a clinical implication for integrated periodontal regenerative therapy of periimplantitis. Follow-up studies include a timely application of chemotactic Q to recruit body's own stem cells. Small molecules and in situ gene editing tools are being investigated as alternatives to growth factor delivery. I would like to express my special thanks to Dr. Lee, who gave me this opportunity, and our lab member for their full support, and my department. Thank you.
Great job. Does anybody have any questions? Okay, we have a question. Timothy, you can unmute.
Sure. Hi, Dr. Wu. Tim Gadzella, University of Alberta. Thanks for a really cool talk.
Yeah.
My question is, do you think mechanical stimulus of your gels during the formation of these tissues would influence the structure of the collagen that you're seeing forming in the mineralized tissue?
Yes, actually, it was a great question because this was a second or third running of the experiment, but previous study included a thicker gel, and then I used in this case I used a half of that concentration because actually thicker gel made it the cells more rounder. So somehow the cells look more entrapped in the gel, so I had to reduce the concentration half. But then I checked the integrity of the gel; it's a lot more viscous than we think. And then also a clinical application, I think is still, I think, feasible in terms of in actual use.
Wonderful. Thank you.
Yep. Thank you.
Any other questions? You can raise your hand or ask in the chat. Okay, we have 1 minute to transition. Thank you, Dr. Wu.
Thank you.
We will wait till 11:24, but in the meantime, Shaolin, if I'm pronouncing that correctly, you can set up your screen. She is
Perfect. Thanks.
Okay, and so sorry, excuse me.
It's all good.
And he will be presenting on marginal bone loss around dental implants, a radiographic retrospective analysis.
Can you hear me fine?
Yes, audio is great. Good. And I can
Awesome.
see your screen.
Perfect. Wait till 11:24.
If you can,
Yeah, no problem.
a few more seconds. Thank you. You're good to go.
Awesome. Thank you all for being here. My name is Shaolin Shah. I am currently a fourth-year student at Tufts University School of Dental Medicine, and my project is marginal bone loss around dental implants, radiographic retrospective analysis. I just quickly want to thank Dr. Papathanassiou, my principal investigator, as well as my colleagues for their support throughout the study. And I have no financial conflict of interest to report. All right, so 2 years ago, I was part of a study where we looked at long-term survival rates of implants placed in the PG Perio department at Tufts Dental. And during that very lengthy screening process, we found 1,900 implants that had a great survival rate. But what we wanted to do was look at implant success, not just survival, and in particular, focus on marginal bone loss around implants with various risk factors. So marginal bone loss, or MBL, as I'm going to refer to it from now on, is inevitable. And during the first year of implant function represents normal remodeling after the inevitable bone injury caused by the implant surgery, as well as the trauma when it's loaded and in function during mastication. However, when MBL occurs in the first year of function, it has been associated with diseases like periimplantitis, which is an inflammatory reaction associated with a loss of more than 2 millimeters of supporting bone around an implant after its first year in function. Now, although 0.5 to 2 millimeters of MBL is usually reported within the first year of function, there's no consensus on the threshold of bone loss that is considered physiologic or pathologic. So MBL around dental implants plays a key role in the increased risk of developing peri-implant diseases. And although several studies have focused on the investigation of MBL, the physiological MBL during the early stages of wound healing are still unclear. And what's also unclear is how MBL affects the long-term stability of bone around implants, the success of the implants, as well as the possible risk indicators at the implant and subject level that could affect MBL. So pre-2017, many studies suggested that 2 millimeters should be considered the radiographic threshold for pathologic bone loss. But in 2017, the American Academy of Periodontology and European Federation had a workshop and determined that if a clinician does not have previous radiographs of the implant, that 3 millimeters should be classified as the pathologic MBL. But if we do have previous radiographs, then 2 millimeters should be classified as pathologic MBL. And although this is what was determined, there is still plenty of debate as to what thresholds should be followed. So expanding on what I just discussed, the objective of the study was to determine the prevalence of implants that have pathologic MBL when applying two different MBL thresholds. And this was accomplished using radiographic measurements with the criteria that I'll speak about at the next slide. And then we wanted to discover any associations between risk indicators and MBL at those two different thresholds. So a query was conducted with IT at Tufts Dental to give us access to records of all implants placed by the PG Perio department between January 2004 and April 2018. And those charts were provided to me for me to begin screening with a pretty strict inclusion and exclusion criteria. So the inclusion criteria was having single or multiple implants placed in the maxillary mandible, and they had to have been restored with either single or multi-unit restorations, but no implant overdentures. They also have had to have appropriate periapical radiographs at the time of implant placement and at least 2 years post-loading with minimal distortion for allow me to make adequate measurements. And they also had to have been TI Unite surface, so Nobel Biocare implant. And we measured MBL at the time of implant placement and at least 2 years post-loading, which are the two right over here, the figures. So implant at time of placement and then at least 2 years post-loading. And then I would measure from the mesial and the distal implant shoulders to the bone level and from the shoulder to the apex of the implant. And then we adjusted for distortion based off of what the actual length of our implants were. And then next we took into account the patient's age, the gender, length of implant, diameter of the implant, whether it was narrow, regular, or wide platform, the location of the implant by quadrant, the type of retention of the prosthesis, whether it was cement or screw retained, the type of prosthesis, whether it was a single unit crown or multi-unit, whether bone augmentation was done months or years prior to implant placement, or if any kind of augmentation was done at the time of implant placement. So we screened 1,884 records to get 403 eligible implants that we used for our study. And this table shows the distribution of implants that fall at or below the respective thresholds of 2 millimeters or 3 millimeters when categorizing marginal bone loss. To no surprise, the prevalence of pathologic MBL decreased from 39% to 12% when the threshold for pathologic MBL increased from 2 to 3 millimeters accordingly. Now this table is the real meat of the project. We have two sets of 3 columns that break down our analysis for if our threshold is 2 millimeters or 3 millimeters. So, on the left side, we have the 2 millimeter category with 246 implants with less than 2 millimeters of average MBL and 157 above, and then 354 implants with less than 3 millimeters of MBL and 49 above. And where we found associations were with a threshold of 2 and 3 millimeters with the type of prosthesis, where multi-unit prosthesis showed significantly higher MBL compared to single unit prosthesis. And then we also had cement retained prosthesis showing significantly higher MBL compared to screw retained at a pathologic threshold of 3 millimeters. And then neither the type of bone, at the time of implant placement or any augmentation, or if there was augmentation done at the time of implant placement, had any association with MBL over time. So in conclusion, the data indicates that modifying the MBL threshold from 2 millimeters to 3 millimeters might underestimate the number of implants that demonstrate pathologic MBL, a number that dropped from 157 implants out of 403 to 49. And based off what we saw in our results, multi-unit and cement retained prosthesis showed significantly higher MBL compared to single unit and screw retained prosthesis, indicating higher risk for peri-implant diseases. And this retrospective longitudinal study with enough analyzed implants provides valuable information to the clinicians for monitoring peri-implant health and assessing the risk for MBL and peri-implant diseases. That's all I have.
Great job. Does anyone have any questions? You can raise your hand or you can type it in the chat and I will ask. I hear someone. Good, okay.
Dr. Carlsen,
Yes, Dr. Romanos, you can ask your question.
the question for the speaker. and the group. Dr. Shah, nice presentation. I have a question in regards to your data analysis. Do you think there's not any problem to discuss at least that there are no standardized radiographs here? My concern is if we show MBL in relationship to the cresta, to the platform of the implant without to have standardized radiographs, that maybe we over or we under treat the patients.
Could you repeat your question, please?
Yeah, my question is, in your presentation, you go based on the Axiom data and you see the MBL according to the platform of the implant placement, etc. But your radiographs are not standardized radiographs. So if
Right,
we don't have standardized radiographs, I know how it's in the clinic, but in a prospective study is different than in a retrospective analysis. My concern is basically possibly that we overestimate the situation and sometimes we overtreat the patients because of crestal bone loss.
Right, and you know, the lack of standardization is, of course, a limitation in particular to this study. One of the things that, or I guess the fallbacks was, there was a lot of issues with lack of radiographic follow-up. So what I would hoped with a study like this is to almost emphasize the importance of consistent radiographic follow-up in a standardized way to hopefully allow for periodontists and clinicians to track it accordingly. That way, you know, there can be a little bit more, you know, high quality follow-up.
This is my concern.
Yeah.
Thank you.
You're welcome. Thank you.
Any other questions? If not, we can move on. Thank you for a great presentation. Okay, next we have Catherine Ellis from San Antonio. You can set up.
Hi, can you hear me?
Yes, audio is great. Can you share your screen?
Yes.
Okay, and you can begin whenever you're ready.
Okay, thank you. Good morning, everyone. My name is Catherine Ellis, and I'm a current third-year dental student here at the UT Health Science Center School of Dentistry in San Antonio. And today I'll be talking to you about implant-specific cleaning aid selection through anti-biofilm efficacy and titanium oxide stability assessments. So peri-implant diseases start off as peri-implant mucositis, which is just simply inflammation of the mucosal tissue surrounding an implant. And if left untreated, it can progress to peri-implantitis, which is that inflammation coupled with bone loss surrounding the implant. So our goal as practitioners is to prevent this progression to peri-implantitis. So what causes this bone loss? Well, like we've already talked about, similar to periodontitis, this is going to occur primarily as a result of an overwhelming bacterial insult and the subsequent host immune response. So years ago, Salvi and some of his colleagues determined through some animal models that plaque accumulation in peri-implant tissues actually leads to a more severe defect than the same plaque accumulation does in periodontal tissues. And this is important because peri-implantitis also causes a much more rapid tissue and bone destruction. So good implant hygiene is going to be imperative in our patients to prevent any kind of biofilm formation. So the aims of our research were to establish an implant relative reproducible ex vivo biofilm model, then use this model to grow viable biofilms on titanium implant surfaces. Then we developed a peri-implant cleaning translational model in vitro to assess biofilm removal efficacy. And we also assessed implant surface alterations via measuring hydrophilicity. So first of all, we took a plaque sample from a severe peri-implantitis patient in our clinic, and then expanded that under anaerobic conditions to generate a diverse microcosm biofilm. We then seeded that on some titanium discs to develop implant-bound clinically relevant biofilms and analyze these using fluorescence microscopy to determine what our optimal growth conditions would be for this biofilm. So here, all of our green cells are going to be our live cells, and the red are going to be the dead bacteria. So here on the left at 24 hours, we see that this disc is very scarcely populated with any live bacteria. However, moving on to 48 hours, we see that there's a very dense multi-layered biofilm that's mostly composed of those green live bacteria and very few of the red dead bacteria. Now, moving on to 96 hours, We have very limited colonies of live bacteria at this time, and it's mostly those red dead bacteria. So our optimal growth conditions for this biofilm model are 48 hours. We also characterized this biofilm using Hohmann probe signals, and we found 54 distinct genera in this biofilm that were very representative of communities that are found in human peri-implantitis. The other thing to note here is that there was remarkable community reproducibility after freeze-thaw cycles with this biofilm model. So the next thing we had to do was grow these on titanium implant surfaces. So we used the same clinical sample from our severe peri-implantitis patient and grew them at our optimum time of 48 hours. We then stained these discs with crystal violet and extracted the solution to analyze. After analyzing that, we noted that our 1 to 50 dilution was going to give us the most consistent high density biofilm with a minimal standard deviation. So we decided to proceed with that. And here's an example of that biofilm here at a 4x magnification. And in the image below, you can see the actual surface architecture of the biofilm, indicating to us that it is dense and multi-layered. And if we take a closer look, again, we see mostly those live green bacteria here, very few of the red dead bacteria, and a very dense multi-layered biofilm. So the next thing we have to do is attempt to clean the discs. So we took a pre-cleaning image with fluorescence microscopy and then scrubbed this disc with a fiber-free pure brush for 30 seconds. We then washed it with PBS and took a post-cleaning image. And here we can see that we've definitely disrupted the biofilm, and it's less dense than it was before we cleaned it with the fiber-free brush. Our next step was to use a prototype water jet called a bacturator. I have a short video. So it uses pretty high power water jet stream to clean the surface. And again, here's our control as an uncleaned disc. And then with the bacturator, you can actually see that we've virtually eliminated all of the bacteria that was on the surface of this disc. So that was very encouraging to us. The last thing that we did was took a look at any hydrophilicity changes to the surface of the titanium. And we did this by measuring water contact angles. So pre-cleaning, we can see that this disc actually has a relatively low water contact angle, but this is misleading because at this point we have seeded a biofilm matrix on the surface of this disc that is composed of an extracellular polymeric substance. So this is polysaccharides, proteins, nucleic acids, and all of these things adsorb water, creating a hydrophilic surface. So this is in no way an indication of the implant surface wettability on the titanium disc. Now, post-cleaning, we can see that the water contact angle has increased. And this tells us that now that we've removed the biofilm and the water is coming into contact with the titanium again, that surface has changed. It no longer has the quality and the osseointegration potential that it did before it was in contact with the biofilm. So that was a really important finding for us to note. And I just want to say thank you to everyone, especially my mentor, Dr. Katsakis here at San Antonio, who helped to make this research possible. Does anyone have any questions?
Great job. Wonderful presentation. Trying to see if we have any questions here. No, we have a clap. Good. Okay, if there are no questions, then we can move on.
Thank you.
Thank you. Our next presenter is Victoria Chang from Boston. Is Victoria here? Okay, hi, Victoria.
Yes, hi. Okay, let me share my screen. That was a great presentation, Catherine. I really enjoyed it.
Yes.
Let me share my screen. All right, are you seeing just like the PowerPoint?
Yes, with the slides on the side.
Okay. Oh yeah, let me put it in present mode. All right.
Perfect.
Okay, hi. So my name is Victoria Chang, and I'm currently a third-year pre-doctoral student at Boston University School of Dental Medicine. I'm representing my team, which consists of my classmate, Nicholas Dulac, and our PI, Dr. Albert Price, from the Department of Periodontology. So today I'll be presenting on challenges in optimizing inter-rater reliability for implant planning with CBCT. And I also had the privilege of presenting for the SCADA competition, so I'm using the slides for that. So to introduce some of the background and to share our aim, as we all know, dental implants are becoming increasingly popular as a treatment option for both providers and patients. Accurate treatment planning is really critical preoperatively, especially for the safety and success of implant placement. And when placing implants, one should consider the adjacent anatomy and the alveolar bone morphology, in particular, the mandibular cuspid site, which is going to be our site of interest. The significance of the mandibular cuspid site is that providers often tend to replicate its natural long rootedness in picking implants, and the site is also used for overdentures. And the mandibular cuspid site has a lingual bone profile that can be classified in 3 ways: straight, convex, and concave, as illustrated in these radiographs. I also included a radiograph where you can see the presence of lingual foramen. And in the literature, it's been reported that a concave lingual profile, pictured third, is more high risk for likelihood of lingual fossa perforation and a post-insertion hematoma forming, which can lead to elevation of the tongue and suffocation, life-threatening airway compression, which is really awful clinically. So to share our study aim, our group aimed to compare the inter-rater reliability between 2 different samples using a strengthened step-by-step protocol from our calibration in between the 2 periods, in between the 2 samples. So to outline our materials and methods, we were analyzing cone beam computed tomography, CBCT scans, using the InVivo 6 Anatomage software. To begin, my classmate and I, serving as examiners, had a calibration period where we tried to standardize how we would evaluate everything. And we included some of the radiographs that demonstrate how we oriented everything 3-dimensionally. So in the sagittal plane, we would set up a line from the anterior nasal spine to the posterior nasal spine, in the transverse plane from the incisive foramen to the odontoid process of C2. And after we went through this entire calibration period and agreed on everything for how we would approach the measurements and data collection, we created a bone profile for a prosthetically driven dental implant at site number 22 on these CBCT files that had the tooth number 22 existing. And we chose to do so the use of dentulous CBCT files as pictured in the third picture, because we wanted to accurately replicate a crown down approach and a pros-driven implant placement. So you can see here, we line up the align with the long axis of the tooth that's existing. And after, included in creating the bone profile, our data collection entails of taking measurements of the buccal lingual widths in 2mm vertical increments perpendicular to a line that connects the mid-buccal and mid-lingual bone socket margins from the crest of bone, progressing downward apically up to 12mm. And we also indicated in our analysis if there is a straight, convex, or concave lingual plate profile, as well as the presence or absence of foramina. And afterwards, we calculated the statistics and inter-rater reliability utilizing Cohen's kappa. And then we worked together to improve the inter-rater reliability. We were just brainstorming, talking about how the process went. We decided to increase the sample size from the original 10 files up to 45 for our second sample. We tried our best to strengthen the calibration through alignment, orientation, and definition of the boundaries in order to maximize the slice selection between the 2 of us. And this resulted in an enhanced protocol that we would use for repeating steps 2 and 3 for the next part of our project. So we speculated that further calibration with a more thorough step-by-step protocol in addition with a larger sample would improve our agreement. So the first part of our results, you can see I kind of blew up the picture from the previous slide, and I share here on the left the mean buccal lingual widths at vertical 2 millimeter increments, and in blue the 8.25 millimeters, because it corresponds well with the highest incidence bone profile type of concave at 40%. So 8.25, like there's a little bit of a concavity, and also we had a 2.96, about a 3% incidence of lingual foramen. To continue our results section, I just illustrated here the step-by-step of our project. And surprisingly, so we had speculated that the inter-rater reliability would improve. However, we were really shocked and surprised to find that our inter-rater reliability actually decreased from a fair agreement after data collection 1 to a slight agreement of 0.13. Even though we had increased the sample size from 10 to 45 with the scans we analyzed, and taking those efforts to improve IRR using a more stringent standardization and step-by-step protocol. So we considered the ratio of ICAT versus Galileo scans as well, because they differ a bit in terms of like the image resolution, and we counted and we found that the ratio was very comparable. So ICAT to Galileos for the 10 scans was 10 to 90 versus 11 to 88.9 in the second of 45 scans. And we discussed it and thought that perhaps this, we thought like, oh, could it be like these differences to improve like the inter-rater reliability? Could it be due to like, are we defining the boundaries differently? Are we picking different slices? Do we have different like ideas of the anatomical landmarks? Is it the contrast variance, which is where the ICAT versus Galileos comes in? So we were wondering like what contributed to our lesser agreement, and then we were really surprised to find that our agreement went down even more. So to wrap it up with our discussion and conclusion, the two of us agreed that we had similar challenges in our slice selection and distinguishing of anatomical landmarks and boundaries when creating the bone profiles. We had considered, as I shared, the contrast variance and lack of contrast standardization between the two samples, as ICAT versus Galileos differs a bit in the quality and resolution of images. Because they were comparable, however, we realized there's a greater need for considering additional factors for that decreased IRR after recalibration. For instance, to keep thinking about how to strengthen the slice selection, perhaps the placement of that initial parallel line along crest of bone, the identification of a true buccal and lingual border on the bone profile, as sometimes it's a bit wider and fuzzier versus more crisp. Also human eye strain and error, or like the environment contributing, like reflecting off the screen or something. And we also are thinking about other contributing variables to discuss in our analysis. And we find that our project emphasizes the significance of careful treatment planning and interpretation differences between providers, because it's really important to place implants safely and as successfully as possible. And it's important to consider in patients with bone morphology variations, such as a concave lingual bone profile, and those who have proximal anatomy that put them at a higher risk for complications. And it's also important to consider in interdisciplinary care when you're working with other providers to assess and plan preoperatively. And our future directions, a few of them, increasing the number of examiners, increasing the number of CBCT scans used, and also limiting the scan type to solely ICAT versus Galileos. So that's everything for my presentation. Thank you so much. Does anyone have questions or comments?
Thank you, Victoria. Great presentation. We do have one question from Dr. Romanos.
Hi, Victoria. Sure. I don't know if you see me now because I'm in the clinic. Very nice presentation, and I'd like to congratulate you, but I have a comment in the discussion. You brought so many aspects, but in our school, we have worked with the radiology department a couple of years ago, and a missing component, maybe for future plans in your study, is that if you change the Galileos and you go to other types of radiological units and devices, you cannot have always reproducibility of the data. have you considered that the measurements may change because the contrast change, because the parameters are changing, you know? Have you considered that for future study?
Mhm. You mean kind of considering how our measurements and everything would change
Correct.
based on
So we
limiting the
did a
scans to one type?
Correct. We did a study in the past in our school where we transferred the data to another institution using
Mhm.
different devices, or we used different devices from the same patients in our school, in our department, and we had completely different data or
Oh,
conclusions.
that's really interesting.
That's why I bring it up. Because, you know,
Mhm.
the explanation of the data from radiologist to radiologist can be different. And you have here beautifully described the reproducibility of the data in between the examiners, but also the radiological unit maybe changes the final conclusion, you know, for the provider.
Mhm.
Just a
That's a
comment.
really great point.
Presentation.
Yeah, that's a really great point. Thank you for bringing that up. I guess that is something we could take for our future direction and to consider in our discussion too. We were also thinking about comparing perhaps our measurements to like the gold standard, like having a radiologist or someone experienced, like analyze the scans as well, and then seeing how our measurements compare. But yeah, so many like different ways to take it. I really appreciate that comment, Dr. Smith.
Thank you. Dr. Romanos, Dr. Smith's
Oh,
computer.
Dr. Romanos.
Yes.
Thank you.
Congrats.
Thanks.
Okay, great job. Good conversation. Next, we have Nicholas Tipton from the University of Texas. Hello, you can
Hello.
share. Good. Audio's good. You can share your screen whenever you're ready.
It says host disabled participant screen sharing.
Are you here as a co-host or?
I'm not sure.
Okay, try now.
Okay, I think that's it.
Okay.
It's giving me some problems. Do you mind if I present at the end and see if I can figure this out?
Okay. So next then we have Dr. Rincon. I'm sorry if I pronounced that incorrectly.
Hello.
Hi. Hello. How are you?
Yeah, it's Valencia Rincon. We have two last names, but yeah, that's fine.
All right. Are you all set to present?
Yeah, I am.
Okay, great. You can share your screen.
All right. Let's see. Let me share it. Do you guys see the screen?
Perfect.
All right. Good morning, everyone. My name is Juan Valencia. I'm a second year resident, periodontics resident here at Marquette University, and I'll be presenting some preliminary studies and results of my study titled Early Postoperative Patient-Reported Outcomes Following Implant Placement. Just a little bit of introduction. We all know that implant placement is a very effective surgical technique in order to restore a missing tooth. This procedure encompasses many physiological and psychological changes in our body, including swelling and pain. So that is why the aim of this study is to appraise the patient-reported outcome measures, or also called PROMs, over time during the first 2 months following single implant placement surgery. Went a little bit into the materials and methods. So we had in our inclusion criteria, adult patients from 18 to 75 years old in good systemic health conditions with a stable periodontium, and not really any limitations in terms of where we were placing the implants, but it must needed to be a single tooth bound site. In terms of the exclusion criteria, we We didn't include any patients with systemic conditions that would compromise the healing or the swelling, and that were not smoking or pregnant, and the inability to take ibuprofen. We wanted to mimic just a real scenario, placing an implant and then telling them to take some pain medications like ibuprofen. Again, with the materials and methods, so what we did is we tried to standardize as much as possible each post-op. So what we did immediately before placing the implant, so immediately pre-op, we did an OHIP 14 questionnaire, which is a series of 14 questions to the patients, mostly psychological and emotional questions related to the treatment that they were going to be receiving. And also we did a visual analog scale for pain and visual analog scale for swelling. These two scales go from 0 to 10, depending on if they have severe pain, no pain at all, or moderate pain. And then we did the exact same thing for 2 days post-op, 7 days post-op, 14 days post-ops, and then a 2 months post-ops. We chose this series of post-ops because we wanted to standardize as much as possible and to see the changes in swelling and pain. So going into the results so far, when I presented this, 16 patients have participated. In terms of the age, mean average 56 years old, gender just 9 females, 7 males. And in terms of the anatomical location, we had 2 from the anterior section, and then mostly they were all premolars, 8 premolars and 6 molars. So what we found out in terms of the visual analog scale for pain, that from pre-op to 2 days, there was a statistically significant increase, and then subsequently it dropped or it decreased from the 2 days to 7 days, 14 days, and 2 months. And we could see that from 2 days and 2 months, this change, this decrease was also statistically significant. Similar results for the visual analog scale for swelling, where we saw from pre-op to 2 days an increase. This increase was also statistically significant, and then subsequently a drop, a decrease, which was statistically significant from day 2 to 2 months. In terms of the questionnaire, the OHIP 14 questionnaire, similar results. We saw an increase from pre-op to 2 days, and this change was also statistically significant, and then a subsequent drop in the following post-ops. From 2 days to 2 months, this change was also statistically significant. Then we wanted to correlate different variables, and in this case, pain and swelling, using the Pearson's and p-values. And we saw that for pain in the 7 days mark and swelling at the 7 days mark was strongly correlated. And then similar results for the pain pre-op and the OHIP 14 questionnaire. We saw that at the 7 days mark and the pain pre-op was strongly correlated as well. And same story with the pain pre-op and OHIP questionnaire at the 14 days mark, and pain at the 14 days mark, and with the questionnaires at the 7 and 14 days. So very straightforward study. In our conclusion, oral health related quality of life is most significantly affected by single implant placement surgery at 2 days post-operatively. The patients experience this significant improvement by the 1st and 2nd weeks post-operative, and they return to pre-operative levels by the 2nd post-operative month. So I would say it's a good study just to give the patients a guideline when they ask us how much pain they're gonna experience, how long it's gonna last, how much swelling they're gonna experience as well. So of course, we all know that pain is a little bit subjective, but we have the visual analog scale, which is it's proven to work and to try to quantify as much as possible the pain, and in this case also the swelling. So I want to thank you, all of you, and my director, Dr. Kofina, and of course, Marquette University for giving me the opportunity to present this study.
Thank you. Great job.
Thank you.
Does anyone have any questions? Please ask in the chat, raise your hand, or feel free to unmute yourself. Great presentation.
Thank you.
Okay, if there are no questions, we will move on to the next. We will go back to Nicholas. Perfect, great.
Okay, we can try this again. You guys see my presentation?
Yes.
Okay. So I'm Nicholas. I'm a third-year dental student at Houston. So this project was done last year in conjunction with the prosthodontist and the periodontist departments. So the goal of their departments is to develop a recall system to evaluate the prosthesis and the implants that they place in the department. This year, what we decided to do is a cross-sectional design. The goal of my project specifically is kind of a pilot study to develop a clinical assessment model for these patients. So as we know, treating missing spaces with implants is a great treatment option. A lot of the implant prosthesis studies that are being done are retrospective. So we did want to do a cross-sectional study to kind of see and evaluate what kind of complications are being patients have to deal with present day, and kind of see if there are some some data out there that we can address. So in our study, we used patients that had prostheses that were delivered between 2009 and 2019. We wanted to make sure to stop it at 2019 so that these prostheses that were evaluated in 2021 had some time. So the goal, like I said, was to develop a clinical assessment model. So the three separate objectives that I looked at for my project specifically was the frequency of overall complications, the loss of interproximal contact, and then frequency of broken acrylic in those prostheses. So I picked these because they're commonly cited in the literature, and specifically the interproximal contact is a complication that we saw quite often. And so this is the methods of the study. So we did an EHR recall of these patients. We called them in to come in and do a clinical assessment. We categorized the data. We used a general linear effects model, and then we took a look at the data. And so in total, we had 149 prostheses. Some patients had multiple that we looked at the same clinical assessment day. We used the generalized linear effects model while recording binomial responses based off of complications. Yes, did they have them? No, if they did not. And then the treatment length was measured based off of number of days between delivery of the prosthesis and then the time of the assessment. And so for the first objective, we saw that there was a correlation between overall complication and treatment length. The complications that we used for this assessment were ones that were commonly cited in literature, such as broken porcelain, lack of retention, lack of broken acrylic, things like that. And the p-value was 0.09. And by comparing the complication frequency to treatment length in days, what we were able to do is kind of extrapolate that out using the slope and compare it to different sources of literature based off of how they measured their complications. So after 100-day complication rates were about 3.7 in our population. The second was loss of interproximal contact. There were 120 single units that we had in our study, p-value of 0.016, pretty significant association there. And then you see here the probability of having this complication in this population after 100 days was about 5.83. So for the third objective, broken acrylic frequency, there was only 15 in this study. 1 second, sorry. And so our sample was pretty small. The p-value was very high. There wasn't an association that we saw with this data, and the 100-day probability of a complication was 3.41. And so our study was able to, create the basis for a clinical assessment to be used in the future. We had an overall 5-year complication rate of 67.5. So comparable studies had about 39.5. It's hard to compare because, how you assess the patients, what complications you take into account. So it's going to be kind of hard to compare it to the literature. And also from the fact of the length of the study, many sources of literature had longer studies that made it kind of tough to compare our findings with. So for interproximal contact, the 1-year overall probability was about 11%, and an 8-year of 29% in French's study in 2019. Our 1-year probability was about 21%. And then for acrylic breakage, it's a very commonly cited complication for prosthesis using acrylic. So the 1-year probabilities in other studies have been shown to about 9.5, something like that. Our analysis was about 12.41. Our association, our p-value was pretty high, so it's tough to make a strong comparison there. But in the future, we hope to have more, larger sample. So in conclusion, we did see an association between time and overall complications, which was expected, but at a lower rate compared to the literature. We had a low association between acrylic complications and time. The interproximal contact and time, there was the expected association, but it was a higher frequency. And so what we want to do is extend the study, maybe control some of the skews, especially with the acrylic study. So it was successful in kind of laying the foundation for developing a assessment model to be used in the future, so we could have some more robust data. Let's see. And then, like I said, with the limitations, being a cross-sectional study, it's always going to be tough to get patients to come back, especially after a certain number of years that they've had, their treatment completed. So it's tough getting patients in. You also have to take into account that if patients are having a major complication, that might be something that gets taken care of, before the time of assessment. And so it may kind of change the data a little bit. And then, and so you also have to keep in mind that, patients that got the prosthesis in 2009 may be very different with the amount of complications they deal with compared to the 2019 patient. And then this was a part of the student research program at Houston with this grant, and then also Dr. Loza, who helped me with this project. Any questions?
Thank you. Great job. I'm checking the chat. The chat is empty.
All right. Thank you, everyone.
Thank you. Okay. Our last presenter now is Dr. Wong. She is from Stony Brook. Hello.
Hi. Sorry, I'm in the clinic, so it's a little noisy out there. Give me 1 second, okay?
Your audio sounds great.
Oh, great. Hold on 1 second. So how is it? Can we see this?
Yes.
Perfect. So let me just mute myself really quick. Okay. So my presentation, hi, I'm Zicha Wang, and I am currently a 2nd-year perio resident from Stony Brook University Perio Department. My presentation is on the irradiation of implants with CO2 laser. And the title, as the title said, it does not release the titanium particles. And the reason that why we're doing this, as an introduction, you could see that peri-implant disease have been associated recently with the presence of titanium particles and ions in the peri-implant tissue, and that have a significant impact on peri-implant crustal bone loss. So previous studies from our lab also showed the presence of the titanium nanoparticles after instrumentation with the most common instrumentation, such as stainless steel curettes or ultrasonic devices. So we're seeing if there's the other methods of debridement around these implants that would not release the titanium particles. So our objective of this study was to evaluate the presence of titanium particle after decontamination of implant surfaces using the CO2 laser. And also as a control, we had the mechanical instrumentation with titanium curettes, and it is a in vitro study. So our methods, so again, we're using the CO2 laser. It's from Denta 2, and you can see the information from the company, and that was used to irradiate the implant surfaces of 2 implants placed in type 2 bovine bone block with the simulated 3-wall peri-implant defects, as you can see from figure 1, the left and the middle figure. And so the defect is about 3 by 4 by 6 millimeters in depth. And so the CO2 laser was used in a non-contact mode, in a defocus beam, which is a continuous beam, in 2 millimeters away from the implant surface at a 45-degree angle, again, in a continuous wave, in a 2-watt output power. And then this defect was filled with distilled water before irradiation. And also after the radiation, and then the implants were irradiated coronal apically for a total of 30 seconds. And as you can see from figure 1, again, that's the position of the laser, the CO2 laser beam head. And we used the endodontic paper points to collect this liquid from this sample, and the 20 samples total per sample was collected to do a chemical analysis, chemical composition analysis, elemental chemical analysis. And so these 0 paper points is collected after 15 seconds and after 30 seconds of irradiation. And also titanium curette was used for implant instrumentation in figure 1, as in figure 1. So again, the chemical composition analysis of these liquid sample before and after the irradiation and instrumentation were examined using an X-ray fluorescence spectrometer. The reason why we did 15 and 30 seconds, as we know from previous studies, the CO2 laser will likely to increase the cause the thermal effects of the titanium implants. Therefore, we want to see if there's 15 seconds and also 30 seconds without overheating the implants. And from the results section, what we saw was that titanium ions were non-detectable at baseline and at 15 seconds and 30 seconds after the irradiation with the CO2 laser compared to the titanium curettes instrumentation. And as in figure 2, you can appreciate the left panel, the left figure is the semi-quantitative spectrometry analysis of the CO2 laser. And at the right side, you could see the titanium curette composition, elemental composition analysis. And so from figure 2, the left figure, you could see the red is the before the baseline, and the green is actually 15 seconds after the irradiation, and the blue is 30 seconds after the irradiation. And normally where we see a titanium peak will be about the 4.5 where the arrow is pointing. However, we don't see anything. The data didn't show any of the detection of these titanium ions. Whereas on the right side, using a titanium curette as the debridement or debridement method, and you could see the peak. Again, the red is baseline, and the green green lines are the after the instrumentation of 30 seconds after the instrumentation, and you can see the peak of the titanium particles, and it's pretty consistent in all our samples as well. And the mean value of 0.007 parts per million of titanium ions were found from the titanium curettes. However, the titanium ions, we were not certain if it's from the titanium implants or the titanium curettes. The release, I was not sure which one it was from. But for the conclusion of our study, that irradiation of titanium implant surface using a CO2 laser does not release the titanium ions or nanoparticles compared to the titanium curettes, and also from our previous study using stainless steel curettes or ultrasonic devices. And it could maybe used as a safe decontamination methods for the dental implants in regards to peri-implantitis cases. Thank you.
Great job. Does anyone have any questions? Please ask in the chat or raise your hand or unmute yourself. Okay. Thank you. Okay, everyone, if nobody has any other questions or any other discussion points, I think this was a great session. There's a lot of exciting new research coming up, and this is great for our specialty. But okay. All right, everybody, enjoy the rest of the meeting and have fun.
Thank you.